No. So one reason too many, stress incontinence. Cause of stress, urinary incontinence, usually older women. Primarily, this is a problem with bladder sphincter function, resulting in urine leakage at inappropriate times, right? You're gathering with your friends, you're having a good time, you're laughing, you're peeing all over yourself. Not a good time. You're out playing, tennis or whatever people do, because I need to be more active. I don't do that. Yeah. Inappropriate times. So, childbirth, multiple childbirths, medications, like I mentioned, obesity, and we have a lot of problems with that in Black females, trauma, or any neurogenic type problems. So numerous problems as to why we can have stress incontinence. Weak pelvic floor muscles, being overweight, pregnancy and childbirth, persistent cough, chronic constipation, menopause, and aging. So let's not be stressed. Here we have the bladder here showing you what the normal pelvic floor should look like. You can see the intact muscle around the urethra. And then the second one where it's opened. The third one, as the increased intra-abdominal pressure happens, then of course there's going to be leakage. Signs of stress incontinence, sneeze and pee. With this particular incontinence, there's no urge issues, right? Because it's not a problem with the detrusor muscle, the muscle surrounding the bladder or the bladder muscles. So there's no urge, like you gotta go, gotta go, gotta go. And no nocturnal symptoms either, because you're not up and about and having an increased intra-abdominal pressure. It's a matter of you being awake and alert, you're sneezing, laughing, coughing. So these are the signs of that. The Q-tip test, I've never done it before, but it's a part of the medical literature, where you would put a Q-tip in the urethra and you would ask the patient to strain or cough or anything like that. Any deflection greater than 30 degrees from the horizontal position will actually indicate that there's some hypermobility of the urethra. That's a very, it's not used as often. So there are no meds for stress incontinence, right? Because we're not talking about the bladder issues in terms of a nerve or anything like that. We're talking about the pelvic floor. So the treatment of stress incontinence usually would be using pads so that you don't, wet all over yourselves, behavioral interventions, Kegel exercises, and then of course, if none of those work, then surgical options can be used as well. So, there's not much data there for pharmacological treatment for pure stress incontinence. Kegel exercises, most of us women who've had children, we know what these are that we can do. And I will, if we have time, I didn't time myself, then I could probably, illustrate what that is. But maybe estrogen, right? Other than the fact that there are no particular medications for stress incontinence, but, loss of estrogen in postmenopausal women may contribute to the symptoms of stress incontinence. So some estrogen can be used, not oral estrogen because of the side effects and the bad profile of having estrogen like that. But the best thing would be topical in the form of creams, lotion creams, or tablet inserts as well to try to help this. Non-surgical treatment, of course, bladder training, double voiding, meaning that void and this one is not for stress incontinence, this is for overflow incontinence, but to be able to void and then wait a few minutes and go back to void again. Scheduling toilet trips as well, every, whatever time frame you want to use, and of course, fluid and diet management as well. Other techniques, Kegel exercises, right? To strengthen the pelvic floor muscles. You tighten the muscles, hold for 5 seconds or whatever length of time you want to hold it, then relax. Tighten, hold, and relax. And you want to do that for, a certain amount of time. It doesn't even have to be just what is written here, but as many times as possible to be able to train. One thing that I saw is that, and I think this would probably be better than the typical sit and hold, tighten, squeeze. Sit on the toilet, on the commode, and as you are letting the urine pass, then try to stop that flow midway. Hold 5 seconds, 10 seconds, let the urine pass, and then try to hold. And I think, and I've never tried that, in terms of practice, but I think that would be probably a little hard to do. So therefore, if it's hard to do that when you're already flowing, then I think that would be a good exercise for someone to be able to do. Electrical stimulation, where they can insert electrical electrodes into the rectum or the vagina to stimulate and to strengthen the pelvic floor muscles. So there are other things that can be done that are non-surgical. There are devices that are used as well. Urethral insert, like a small tampon-like insert into the urethra. So if you have to do anything important, you don't want to pee all over yourself, then you can actually have that there. Pessaries, these are like tried and true. They've been around for a while. Sometimes they don't work, but of course you would put that inside the vagina at the very base of the cervix, and that pushes up against the urethra to kind of like hold it in place. So the pessary is another way of doing that. And this here is a diagram of the different types of pessary, and you can see the, where the green is there, right up underneath the uterus, pushing up against the urethra. Non-surgical as well, Botox injection, nerve stimulators, and such the like. The surgery, a sling procedure that they would, if you know what a sling looks like, so that sling would go around the urethra, and then they will kind of like tack it to the inside of the front of the pubic bone area there to kind of like pull it in using a sling, right? And bladder neck suspension. And of course, if the patient has a cystocele where the bladder is prolapsed, then they will have to do a prolapse surgery as well. Medications, the medications are for urgent incontinence, like I mentioned before, not stress, right? To calm down the overactive bladder, and of course, topical estrogen. So for a quick recap, as it pertains to women, stress, sneeze and pee, sphincter issues, right? Weak pelvic floor muscles, being overweight, and that's something that we can do to help ourselves. Pregnancy and childbirth, the horse is already through the barn in that regard in terms of the amount of children you've had, but help to tighten up those muscles so we can regain control. Persistent cough, if there's an issue with the cough, then that needs to be looked into as to why that's happening, right? If you're on medications like an ACE inhibitor that causes that, then that can be changed. Chronic constipation, yes, that can be addressed. Menopause and aging, nothing we can do about that. But then, of course, estrogen is what we can use to actually help to increase tone of the sphincter. And the treatment, of course, for stress incontinence would be exercises, pessaries, and surgical sling. And last but not least, urge incontinence is a muscle issue, usually no leak, right? Because it's not a sphincter problem. And it's usually due to a variety of issues that if those issues can be addressed, then maybe the urge will go away. Infections, medications, neuropathies, aging, find and treat the problem, and medications, of course, to decrease the urgency, and also exercises. So that's my recap. That's the end of my talk, and sorry for the technological issues, but this is where we're at the very end. Thank you very much.
Thank you so much, Sonia. We are going to try to answer the questions after both presenters, but I'll just throw this question in since it's so close to what you have spoken. Sure. Uterine prolapse.
Yes.
Would this also result in incontinence?
It can also do that because, of course, that tells you that the pelvic floor is weakened, right? So if the pelvic floor is weakened, if the uterus is coming through, then yes, you're going to have leakage of the sphincter. The external sphincter is right there at the base of the pelvic floor. So yes, also. And that is why one of the things that I mentioned is that they'll do, a double surgery to be able to take care of that prolapse and to also help to reinforce issues there with the urethra.
Thank you very much. Thank you so much. That was really a lot of information, very good information. Thank you a lot. We're going to go right into our next presenter, and Grace is going to introduce to us Dr. Plum. Grace, you can, okay. Grace is muted.
Lorna, check your email. I sent it over to you. I'm doing it on YouTube, so it's giving me bad feedback. Dr. Plummer, my apology. I only know that you're an Arizonian. Your mother taught me Bible at Arison, and Dijon is my friend.
Well, Dr. Plummer has been a family practice specialist in Lithonia since over 22 years. He graduated from the Medical College of Georgia School of Medicine since 1999. So he's very fitting to be our presenter this evening, having had so many years in family practice. We're going to ask Dr. Plummer if he'll present to us at this time. Thank you.
Good afternoon, everyone. And thank you, Grace, and thank you, Lorna, for opportunity for me to participate in this discussion this afternoon about urinary incontinence. I also want to say thanks to Sonia because she has done an excellent job in describing the anatomy and showing the anatomy. And I don't have any fancy slides, so she has set the scene perfectly for me to speak. There's, as you can imagine, a great deal of overlap in urinary incontinence between male and female. So I think I'll just be talking about, well, I'll be reiterating and repeating some of what was already said, and then mentioning some of the things that are just a little bit more specific towards males. And of course, just to reiterate, whenever somebody has new onset urinary incontinence, it's very important to try to identify what is the source of the urinary incontinence, and is this something that can be treated and therefore reversed, which means if it falls into the transient category. And then, of course, if things fall into the chronic category of urinary incontinence, then the treatments are, such as were mentioned before. But just a little bit more specifically about males, how common is urinary incontinence in males? It's estimated that approximately 6 million US men will experience urinary incontinence at some point in their lifetime. So that's a high percentage. And usually urinary incontinence is more common in females, partly because of that pelvic relaxation that Sonia talked about. But once you get to around about age 80, the incidence or the prevalence of urinary incontinence between male and female is pretty much equal. So, of course, if this does not apply to you, it's probably going to apply to your parents or older relatives in terms of urinary incontinence. The categorization or types of urinary incontinence, again, very similar, pretty much the same between male and female. Urge incontinence, which you heard a great deal of. Stress incontinence also, even though we don't have that as frequently with males, but it does occur. And we'll talk about what specifically can make that worse. Overflow incontinence, mixed incontinence, which combines both stress and urge incontinence, and up to approximately 30% of people with incontinence will have mixed incontinence. And then there's another category, which is referred to as functional incontinence. So let's kind of break that down just a little bit more. And again, some of this is going to be what you already heard. Urge incontinence is really that detrusor muscle being overactive, or that overactive bladder, where the bladder muscle walls just want to squeeze more than they should. You see, they're only supposed to squeeze when you're voiding, when you're passing urine. But if they're spasming and squeezing all the time, then you're going to get that urge to pass urine when you should not need to. Stress urinary incontinence, of course, is because of a weak sphincter, and is a very common problem. For example, after prostate cancer surgery. Overflow urinary incontinence. As Sonia mentioned, this is more common in males because a lot of times it is due to an enlarged prostate gland. Let me give you an example. This happened several years ago in my prior practice. There was a gentleman, he was approaching, I think it was 90. I think it was about 90 or 91 years old, but extremely functional. And he came in and he was complaining of urinary incontinence. And so I did a physical examination on him, and I felt this huge abdominal mass. I mean, like huge up to the navel abdominal mass. And so sent him urgently down to the hospital to get evaluation. He had an ultrasound done that showed a huge mass. And so they actually, it was a cystic mass is what they described it as, which looks like a cyst, a large single cyst. And so they did an MRI. And actually what it was, his urinary incontinence, his urinary retention had been going on for a very long time, and his bladder got stretched and enlarged up to the level of his belly button, of his umbilicus. I mean, I think that's the most dramatic I had seen. And so they, I can't remember how many liters of urine that they were able to get out of him when they inserted that urinary catheter. And of course, when you have that amount of urine, sometimes you have to be careful when draining all that at once, because it can affect circulation. But anyway, that's just an example of overflow urinary incontinence, where you may see somebody come in with urinary incontinence, but it's not just a simple the muscle is weak and can't hold it. It's just that the bladder is just so huge. And functional urinary incontinence. And this is more kind of a nebulous thing, and it deals more with reasons why people may not be able to pass urine appropriately. For example, some people have, dementia, and because of that, their mental cues may not be, as appropriate in terms of getting them to void when they should. Or even decreased mobility. For example, some people may have severe hip pains, and by the time they're able to get up out of the chair and to move across the room and to get to the bathroom, then they have a little accident and don't quite make it on time. And so the functional can be basically physical, or even sometimes psychological, psychiatric in nature. We did hear a good bit about how urinary incontinence is managed. And for urge incontinence, of course, just like with females, males also, are prescribed these different medications, such as oxybutynin or clothianidine. And these medications are anticholinergic medications. So let's dive just a little bit more into that and talk about why these medications may be good and why they may be bad. So these medications affect a substance called acetylcholine that binds on receptors and then provides that trigger for the muscle to contract and aid in voiding. These anticholinergic medications kind of help to block that. But anticholinergic medications also have particular side effects. Some of those are dry mouth. They can result in urinary retention. They can increase sleepiness or somnolence, and in some people may end up causing mental confusion. As of such, we have to be extremely careful using these anticholinergic medications in our older patients. And who usually develops urinary incontinence? It's our older patients. So we do have a challenge there. Sonia did mention some of the newer ones, which are what's referred to as anti-muscarinic. And so they don't have quite the same degree of side effects as the traditional anticholinergic medications for urge urinary incontinence. Okay. And some of these are medications like trospium or mirabegron, which is also called Mibertriq. So those for urge urinary incontinence don't have as many side effects for the elderly. Urge incontinence, she talked about scheduled bathroom visits or timed avoiding. It's basically the same thing. And what you want to emphasize in people is, just go to the bathroom every 2 hours. And many of us kind of do this anyway. When you're going on a long trip, a long car ride, okay, every 2 or 3 hours, whatever it is, we're going to stop and we're going to use the bathroom, because you don't want to be, along some long highway where there's no restroom available, and then that urge to go to the bathroom just hits you, and there's no place to go. And so we do scheduled bathroom visits or timed avoiding, just to kind of avoid that. And that is one of the very valuable lessons that you can give people who have urge incontinence. For stress incontinence, it also is helpful to tell people about timed avoiding, but of course, those Kegel exercises, and this goes for both men and women. And so it's correct. It is a little bit challenging, and I ask you all to kind of try doing it yourselves. Is just start passing urine, and then stop it midstream, and just see how challenging that is. But you will realize that after a while, you are able to do it just a little bit more easily, and so it helps you develop that level of control. And so, advise your elders, or if it's pertaining to you, then practice it to help maintain better control of your stress urinary incontinence. For overflow urinary incontinence for males, most of the times folks like that end up in the emergency room, get a Foley catheter placed and a leg bag, and then they have to follow up with urology. Some people some people are prescribed a trial of voiding, where the urinary catheter is removed, and then they see, are these people able to empty their bladder? Sometimes they do studies called post-void residuals, where they have the patient empty the bladder and take an ultrasound and see what's remaining, or insert a catheter after the patient is finished urinating to see how much urine actually remains in the bladder. So some people will do intermittent catheterization of themselves. We see this just a little bit more with people who have neurogenic bladders, which Sonia mentioned. And these people really don't have full control, and so they just have to intermittently catheterize themselves throughout the day. So intermittent catheterization, indwelling Foley catheters, it's probably not the best to have that permanently, as it can lead to trauma or damage of the urethra long term, and also can increase the risk of urinary tract infections. Very frequently, what's done for people with urinary retention, which ends up in overflow because of an enlarged prostate, is a partial resection or surgical removal of a part of that prostate gland. And the transurethral resection is one of the most common things that is done to this point, is most studied. There are other techniques that are used. There are also medications that may help, tamsulosin, finasteride. Those do help shrink the prostate gland just a little bit. But usually when people get to the point of overflow urinary incontinence because of an enlarged prostate, those medications probably are not sufficient, and surgery is usually indicated. Removal of the entire prostate gland is usually not done just because of benign prostatic hypertrophy or BPH. Usually it's done if if there's actually cancer. And that is one thing that has to be ruled out when somebody has a significantly enlarged prostate gland. Needless to say, physical examination would also demonstrate an enlarged prostate gland. I think we've kind of touched on the areas of stress and urge in terms of mixed urinary incontinence and how that's managed, which is going to be a combination of the above method that were just discussed. For functional urinary incontinence in males, and this is where you typically have your older patients who may have some dementia issues associated. And for some folks, they're able to successfully use a condom catheter. And of course, the condom catheter fits on the outside, so it's not as invasive, but it still has some slight increased risk of urinary tract infections or skin breakdown. And so that has to be taken into consideration. Absorbent underwear are very frequently has to be used. Timed voiding by a caregiver giving prompting, that's also very helpful. And pain management, some people, it's because of either knee pain or hip pain that they can't get up and go to the bathroom, and those people, pain management may help. And skin protection is also very helpful. How can I reduce my risk of developing urinary incontinence? One of the first things to do is just maintain a healthy weight. Regular exercise is also very important, and has been mentioned before, avoid constipation. Avoid alcohol, limit or avoid caffeine, and quit smoking. There's something that's somewhat counterintuitive when it comes on to preventing urinary incontinence, and that is avoid dehydration. So when we're dehydrated, our kidney function becomes somewhat compromised, and a lot of people put themselves at risk for urinary tract infections, which can result in urinary incontinence. Avoid holding your urine for prolonged periods of time as well. Some people, they, and I especially see this with teachers, because they can't leave the classroom or they can't get a colleague to cover for them. They just won't drink much water during the day and will hold their urine. And that's not a good thing in the long run. Definitely practice Kegel exercises, even though most of us may not have urinary incontinence at this point in time. Practice Kegel exercises. You have seen diagrams of how to do it. Nobody knows that you're doing a Kegel exercise when you're doing it, so feel free to do it throughout the day. And then these things can actually reduce your risk of incontinence. Are there any vitamins, are there any supplements that may be helpful for urinary incontinence in males? I would like to say perhaps saw palmetto. It is definitely helpful for BPH, benign prostatic hypertrophy symptoms, and may reduce some of the dribbling or leakage that some men may have post voiding after passing urine. Vitamin C has been noted in some articles to be helpful, but of course, excess vitamin C can cause irritation to the bladder and therefore increase urinary incontinence. A lack of vitamin D has been found to increase urinary incontinence. And so, supplementation with vitamin D, which most of us probably need anyway, because we don't get enough sunshine, would be helpful. There is something that I wanted to talk about for stress urinary incontinence in males, and I kind of skipped over it. So if you'll just bear with me, we'll kind of backtrack a little bit about that. And that is one of the most common reasons for stress urinary incontinence in males, because this is a big problem after prostate cancer surgery, prostate cancer treatment. And this is almost regardless of what type of prostate cancer treatment has taken place, whether it's radiation, whether it's surgical, it can happen. And it's always a risk benefit type thing to figure out, and I even have to backtrack a little bit further on this because it goes kind of back to the prostate cancer screening thing, which the experts have gone back and forth on a good bit over the years. Because urinary incontinence definitely is one of the big problems after having prostate cancer surgery. But, and I think I've mentioned this before, I am biased towards, screening for prostate cancer surgery and for getting and encouraging people to be treated for prostate cancer. There's a gentleman who I saw some time ago in my practice, and this gentleman was diagnosed with prostate cancer, elevated PSA. After a while, he did agree and get biopsies done that confirmed prostate cancer, and his choice was to wait, to do watchful waiting. And so for many years, he just was monitoring his PSA, and he would take different vitamins and supplements and so forth that he had read up on. His PSA, didn't go up into the thousands, so it was remaining relatively stable. But at one point in time, he started developing some upper extremity weakness, some weakness in upper extremities, and also some difficulty walking. And when some advanced imaging was done, what had happened was his prostate cancer extended from the prostate gland to the spine all the way up into his neck. And so he actually had to have pretty semi-urgent neurosurgical decompression or removal of the cancer tissues from around the spinal cord in the neck, just because his prostate cancer had spread so much. And so, at that level, prostate cancer is definitely, a life-limiting concern. And so the question is, does one screen and treat prostate cancer knowing that you may have urinary incontinence as a side effect, or do you just kind of let things go and flip a coin as to how extensive and how metastatic, how far spread your prostate cancer would be? And I think this is a discussion that males really need to have with their doctors and with family members, because even though the urinary incontinence is problematic, I personally think that the alternative when it comes on to prostate cancer, especially in younger males, is really significant. So that is the conversation that needs to be had. Urinary incontinence can be managed. One can remain relatively functional. It is disruptive of life. It is somewhat costly because a lot of men end up having to buy the Depends type underwear for it. But when it comes to comparing that to what prostate cancer can do to us, it may be worthwhile doing. Anyways, hopefully this was not too repetitive because Sonia did such an excellent job of going through. But I still see that some folks, I saw a question pop up about Kegel exercises. And so I think Sonia might be best able to answer that by reviewing one of her slides, if you don't mind, because that graphic was just awesome. Thank you.
Thank you, Dr. Plummer. And Sonia I've asked her to cue that video. So we're going to show it in just a short moment.
Not right now.
Before we do that, there's a question that is in the queue that says, when given medication for frequent night urination, does the medication cause fluid retention?
You want to take that one?
Yes, the medication may typically cause urinary retention, not necessarily fluid retention. Fluid retention is slightly different. Usually that's associated more with circulation or cardiac or heart problems, but not so much because of the decrease in urination that comes from those medications. So in general, no, it may cause urinary retention, but not so much fluid.
Okay, and Dr. Dawkins is on. We also have a question regarding diseases. Are there any diseases that can actually, or illnesses that can actually cause urinary incontinence?
That question is for me or Dr. Dawkins?
I was trying to, oh, there he is.
Okay, repeat the question again.
Are there any diseases that can actually cause urinary incontinence?
Well, yes, and just want to thank the docs who presented. Yeah, there are diseases, and you can actually think mechanically, such as if there's obstruction, tumors, and I think that was kind of mentioned, that affects the plumbing, can affect it, cause it. So cancer is something that, somebody may have cancer somewhere in the urinary tract area that could cause it. Then there are other condition that may, cause, people, for instance, to have excessive urine, even something as simple as diabetes, where frequent urination, can be a problem, can also cause it. But you can visualize so many different things. People with heart failure who are on certain medications that causes them to urinate a lot. And as we deal with incontinence, also realize that you have both bowel and bladder constipation. People who have fecal impaction, that also can cause it. So there are a number of things, and if you just think about the whole process, you can actually identify other conditions that could affect that.
I want to add to that as well, too, real quickly. Something that sometimes we overlook is multiple sclerosis. That's something that affects a lot more women than men for the most part. And sometimes it takes a while for the docs to figure out, okay, what is going on with this patient, until they, find a good neurologist to zero in on the fact that the patient has multiple sclerosis. So, with the issues with the nerves, the impairment of the nerves that comes and goes and comes and goes. One day you have symptoms, then it just automatically goes away, you're fine. Then again, so multiple sclerosis is one thing that comes to mind as well, that sometimes gets overlooked.
Thank you. The next question, there are two questions that are very similar. I'm going to put them together. Why do we have to go as soon as we drink water? And the thought of going to the bathroom to urinate as soon as you drink, would that be considered urinary incontinence?
Let me see if I can take that. So there's another aspect which is about training your bladder. And so what happens is a lot of people they don't drink sufficient amounts of water. And so the body doesn't really know what to do with it when it gets introduced to water. And so when those folks drink almost as immediately as soon as they drink, then the body wants to remove urine. I would propose that when one increases the amount of water that one takes in consistently over long periods of time, your body actually learns how to cope and how to manage water. And you will not have to run to the bathroom immediately after using after drinking water as much as in the past. So it's a part of bladder training that will help overcome that problem.
Thank you. We're going to go to the Kegel exercise video after we deal with this last question. The question came in. I understand that most of what was described refers to more elderly people. What advice can you provide to help to zero in on overactive bladder for a male that's about 15, 16 years old?
You said 15 or 16?
Yes, for younger adults.
For an overactive bladder? I
Yeah.
mean, that patient has to be evaluated for diabetes, number one, to see if this, what the situation is. That's the first thing to come in mind. And of course, remember, there are, cancers that someone can have intra-abdominal pushing against the bladder. So yes, abdominal cavity scanning needs to be done, because that would be very unlikely for that to happen at that age usually.
So in the case of a child who wets the bed, like until a very, like 15, 14, 12, 14 years old, is there a situation there that could be addressed in relationship? Would you refer to that as incontinence, or is there other reason why that child is wetting the bed for that long?
If everything else is ruled out, as based on what I was saying before, and the docs can speak to this, if everything else is ruled out, then there has to be behavioral things that needs to be looked at. Is the child drinking more? Because there's a psychological thing as well. There's something also called diabetes insipidus as well too. So when all of these things are ruled out, looking at the pattern, are you drinking a lot of water? Are you drinking a lot of caffeinated products? Kids who want to build muscles or do things that actually cause a lot of, fluid in their system at that time. So asking the appropriate questions, and then do bladder training, nighttime training, setting a clock to go to bed at a certain time, not drink fluids at a certain time, to wake up at a certain time to pee. Once all those things are looked into, then, I don't know what else, but then a urologist has to be able to look to see what, other than the medical parts of it, do a scan to see what's going on. Is it diabetes? Is it a tumor? Then look to see if there are behavioral issues that needs to be addressed.
Thank you very much. All right, we are going to go to the Kegel. There are a couple of other questions, but we are going to go to the Kegel exercise because the question came up in relationship to the Kegel exercise. So we're going to look at it at this time.
The pelvic floor is the base of the group of muscles referred to as your core. These muscles are located in your pelvis and stretch like a hammock from the pubic bone at the front to the tailbone at the back, and from side to side. They support the bladder, bowel and uterus, and play an important role in bladder and bowel control and sexual function. If your pelvic floor muscles don't work well, you may leak when you do things like coughing, sneezing, lifting, laughing, or exercising. To stop this from happening, you need to switch on your pelvic floor muscle. To switch on the pelvic floor muscles, you need to squeeze and draw in the muscles around your vagina, as if you are trying to stop the flow of urine. Lift them up inside. Breathe normally. Don't hold your breath or tighten your buttocks. Then let go and relax the pelvic floor muscles completely. Notice as you tighten and lift your pelvic floor muscles, they tighten and close around the anal passage, vagina, and urethra. By exercising the pelvic floor regularly, you will train your muscles to work automatically when they are needed.
Thank you very much. Thank you. That was a demonstration of how the Kegel exercise is done. And like Dr. Plummer says, you can do it at any time, because while it was going, I was doing it. So, so you just, it's just a matter of cutting your urine flow and starting it again, sucking in, really tightening down there and releasing it. And this can be done whether you are urinating or you are not urinating. So it's a matter of tightening the muscle down in your pelvic area and releasing it. And you can do that as frequent as you can. There's a question regarding the Kegel weights. Dr. Plummer, Dr. Sonia, any of you want to address the vaginal Kegel weight to increase incontinence? There was a question, can either of the presenters speak about use of a vaginal Kegel weights to increase incontinence? Do these work in the elderly females as well? I know that we don't have an incontinence specialist, but maybe one of you three physicians might know of the Kegel weights.
Not to my knowledge, so I'll pass it on. And, I don't work in urology, so I've not heard of that in particular, so I'll pass it one to the other docs.
And I'm not familiar with Kegel weights either. I know when I was rotating through OBGYN in my years as an attending physician for family practice physicians who delivered babies, we never recommended weights in terms of Kegel exercises. But ladies who especially have had multiple children, we do recommend those regular Kegel exercises, and even for patients afterwards who are older who have urinary incontinence, we do recommend it, but I have not recommended weights. I'm not sure Dr. Dawkins has another perspective.
No, myself included, I've never heard of that procedure. So I have to, do something like that. I guess would end up just referring to a urologist. Just this thing to keep in mind though is that the tissue down there is not something that you necessarily want to overstress beyond what is considered normal use for the muscles there, because it can easily cause damage and stuff like that. So as far as how the weights would work, I'm not sure. So I would end up just deferring to a urologist.
The question came from seemed like Dr. Thomas. We are going to refer back if we have the answer, Dr. Thomas, at our next seminar. We'll refer back to it. There's a question as to whether or not there are any natural remedies for overactive bladder instead of medication. I know we are into natural medicines, but is there any natural medicine that can help with overactive bladder?
I think. Oh, go ahead.
Yeah, go ahead, Doc.
Yeah, some of the things that I mentioned earlier, I think is what shows up in the literature, and that is, for example, increasing vitamin C in the diet, especially with vitamin C rich foods. Same thing for vitamin D. Increasing magnesium in your diet may also be helpful, because we know magnesium, especially for urge urinary incontinence, we know that magnesium is helpful in causing smooth muscle to relax more. So those are some of the more natural approaches that one can take. And then, of course, maintaining healthy vitamin D levels through proper diet.
And staying away from things that are stimulant, caffeine, and other things that can stimulate the muscles is also recommended.
Thank you very much.
I'm not a homeopath, or know a lot about that, but I remember growing up in the islands, my grandparents would usually talk about pumpkin seeds, and there's something else I'm thinking of as well too that I can't think of. But soursop, right?
Yeah.
So there are a lot of things out there that the Lord put our herbs and such disposal for use. And as Seventh-day Adventists too, sometimes we have to remember to go back to the basics to know some of these things. However, we have to be careful. If you do have medical conditions, and as African American, Black folk, whatever your nationality is online here, a lot of times we are prone to certain types of illnesses, and we're on a lot of medication. So we have to be very careful as to what we're using out there to help something that we think we can do on our own. So that being said, yes, there might be things that are out there because God puts the herbs here for our use. And, our pharmacopoeia is such that they use these things as well to come up with medications, right? But you'll have to probably do that in line with your physician and with a naturopath to see what can work for you.
I appreciate you for saying that we need to let our physicians or primary care physicians know what we are taking, even though it's not a medicine. So if we go to the doctor, Dr. Dwight says, "What are you taking?" Please tell him that you are drinking soursop leaf 3 times a day, tea, and all of those things, because it is really important for them to know, because things do interact with your medication that you are taking. And you have to make sure that you let doctors know what it is additionally that you are taking with your medicine.
Doctors and nurse practitioners.
Yes. Your providers know what you are taking with your medicines. Thank you so very much. We appreciate those answers. There's one question. We have just a minute to wrap up. So there's one question that I want to ask. It's not directly related to incontinence, but since the question comes up, we would like to ask it, and one of you providers, healthcare providers, can answer for us. Blood in the urine after menopause, should I be concerned? That's our last question.
So, any blood in the urine, should be of concern because it's not naturally there. So that's one aspect. What is causing it, whether it be infection, kidney stone, or malignancy. Those are probably some of the more common causes. When you include the menopausal aspect, then you're not necessarily dealing with the urine as much, because whether it's menopausal or not menopausal, blood in the urine is warranted to be worked up. The menopause would indicate that it would have something to do with your menses. And anytime a female has blood after menses, as far as vaginal bleeding, that also is of concern. Until ruled out otherwise, you think of it being some sort of tumor or cancer. So yeah, the answer is yes. You would be concerned, and it could be something as simply as atrophy. Vaginal atrophy, the mucus becomes dry and can bleed. It could be something as simple as that, as well as it could be, of course, due to a tumor.
Thank you very much. We have come to the end of our webinar. I just want to say thank you so much for coming on. I hope you have gained a lot from what was presented. I have. And this is not the end of our seminars, the end of our health programs. We are going to be having others, and we will be sending you out information as it relates to those. And we also have other things, like I told you, that we are doing, that we always need volunteers to do. We were not able to go out on our annual go out of the country to do our mission trips. However, we are still doing things in the country. We are still doing things around us. So feel free to go to our website, hopemissions360.org, learn about Hope Mission, see what we are doing, and see how you can volunteer or you can financially donate towards the program. We really appreciate you all for being here, and our providers. We are so appreciative of you for bringing your knowledge and for helping us to understand more about urinary incontinence. At this time, I'm going to see if our President Grace has anything to add before we close.